Hello from San Francisco. I'm Ken Binmoeller. I would like to thank the organizers, especially Ping Hong Zhou, for the kind invitation to contribute to the 2021 Shanghai International Endoscopy Symposium. I'll be speaking on underwater endoscopy and resection, a passion of mine for over a decade now. Underwater endoscopy is not new to us endoscopists. There are many examples of underwater imaging that we use in our practice. Video capsule endoscopy is an underwater imaging procedure. In fact, the reason why the images are so crisp and clear and the resolution so sharp is because the images are underwater. Here, this is one of my very first capsule endoscopies from 2001. You can see the individual villi lining this fold here. These images are much higher resolution than one would expect with a simple CMOS chip. These images from the esophagus, the stomach, the small bowel, and the colon are all underwater images taken as the capsule endoscope travels through the GI tract in a water medium. The advantages of underwater imaging are firstly, the magnification effect, which we're all familiar with when we go scuba diving or snorkeling. It's about a 1.33-fold magnification. And the 3D floating effect. There's no light reflection artifact. Halations is what we call these. There's no adhesive fat artifact, something that we frequently have when we use gas. There's no fogging. There's no surgical smoke when we apply cautery. The images are crisp, clear, and very color intense. Cholangioscopy is also an underwater exam. We preferentially use water because we want to minimize the risk of air embolism, but it also gives us much clearer views of the bile duct. In this video, on the left, you see the air view, on the right, the underwater view. When we look at this polyp inside of the hepatic duct, we see it with much greater clarity, and by infusing water, we can interface with the tissue. Electrohydraulic lithotripsy is cut. When we perform electrohydraulic lithotripsy for an impacted bile duct stone, we also require that the stone is submerged in an ionic medium, in saline. Here you can see how the electrohydraulic lithotripsy probe generates a spark wave at its tip, and this plasma spark wave is transmitted to the surface of the stone, but requires an ionic medium. But this is also why the images are so clear. Endoscopic ultrasound is an underwater imaging procedure. Of course, we focus on the ultrasound image. But when we look at endoscopy, we see that we are submerged in water. We need the acoustic coupling to transmit the ultrasound waves to the surface of the GI tract. It was during one of my endoscopic ultrasound exams in the colon, staging a lesion, that I discovered that on ultrasound, the muscularis propria stays round on the outside and does not follow the convolutions of the mucosa and the submucosa. Comparing the left and the right, you see how the lumen contracts, and yet the muscularis propria stays round. So the wall retains its native thickness, and the MP stays round after water submersion. You get a floating effect. With gas, this lesion looks like a Paris 2A lesion. But after water submersion, it looks like a Paris 1S lesion, as if we had injected saline in the submucosa to raise it. This floating effect is not only due to the lack of gravity that we have with water submersion. The submucosa contains a large amount of fat, so we have a true floating effect. Here you can see after EMR, the large amount of fat, especially in the right colon, and we see this as an echogenic layer on EUS in the third layer. I reported our first series on underwater EMR without submucosal injection for large sessile colorectal polyps in 2012. So none of these lesions were initially injected with saline or any solution. 62 lesions, the technical success rate was 100%. The median resection time, 18 minutes. That has now come down substantially below that. Complications were 5% with 9 delayed bleeds, 2 abdominal pain, and there was 1 delayed perforation. Recurrence was only 2%. And this was really remarkable because historically our recurrence rate with EMR had been in the order of 20 to 25%. The advantages of UEMR are firstly that we can eliminate submucosal injection and thereby retain the native tissue thickness and consistency of the wall. It's compliance. And we have a natural wall layer separation. So the mucosa, submucosa, and muscularis propria naturally separate from one another. In fact, the circular and the longitudinal MP layers also separate after submersion in water. We can capture a larger surface area due to a contracted lumen with higher en bloc resection rates. And we reduce collateral injury, the so-called heat sink effect. This is a landmark paper published by Japanese authors from 5 centers in gastroenterology in 2019. A randomized controlled trial comparing underwater EMR with conventional EMR using submucosal injection. These were polyps 10 to 20 millimeters in size, so intermediate size. The en bloc resection rates and R0 resection rates were significantly higher in the underwater group. So this is strong level 1 evidence that underwater EMR can achieve higher en bloc and R0 resection rates. Now, the other outcomes were equivalent. I was very intrigued by this significantly higher en bloc resection rate. So we looked at R data, large polyps, 2 to 4 centimeters in size. And among these 52 patients with a median size of 3 centimeters, our en bloc resection rate was 55%. So over half of the patients could successfully undergo en bloc resection. Now remember, the ESGE guidelines state that any polyp larger than 2 centimeters should undergo piecemeal resection. Adverse events in 4%, no perforation, and recurrence rate 5%. A meta-analysis of 10 studies, 508 lesions, confirmed this very high en bloc resection rate, 57% in these 10 studies, recurrence rate 8.8%. This is a paper that's fresh off the press. It is a comparison of underwater EMR versus ESD for 20 to 30 millimeter colorectal polyps. A Japanese study. The procedure time was 6 minutes for underwater EMR, 6 minutes, whereas ESD took over 1 hour. En bloc resection rates, 61%. So we're seeing again these numbers that are above 50%. Of course, ESD has a near 100% en bloc resection rate, but at the expense of a much longer procedure time. There was no recurrence in either group. And the bleeding rate, although a bit higher in the UEMR group, not significantly higher, and no perforation. There are two limitations of UEMR. The first is the cloudy view. And this is what happens when you have food residue or fecal residue from a poor colon prep, for example, and the view just is too cloudy to see. The solution would be water exchange, so continuously infusing water and sucking out or removing the dirty water. Vigorous bleeding, so vigorous meaning that it's really pumping, it's difficult then to clear that with continuous irrigation. But if you work close to the mucosa, you will be able to maintain your view. But with vigorous bleeding, I will admit that I often have to switch to gas to achieve hemostasis. In the upper GI tract, we have the risk of aspiration. The solution would be to intubate these patients. I don't do it when I'm working in the duodenum, but I do when working in the esophagus or the stomach. Water intoxication, this is where you infuse liters of water, and I want to underscore liters. The solution would be really to use Ringer's lactate. Even saline would be better than distilled water. The last topic is the new frontier, underwater third space dissection. So we have our POEM procedures, all of which can be performed underwater. The E-POEM for achalasia, the Z-POEM for Zenker's diverticulum, the G-POEM for gastroparesis in the stomach. That's the usual indication. There's UESD now, and there's U-STIR. All of these techniques have one thing in common. Dissection is performed underwater. So it is essentially like a pocket method where we are going underneath the lesion and infusing water to create our third space. There are several advantages to U dissection. Firstly, there is a reduced risk of gas-induced adverse events. This is particularly pertinent when performing E-POEM for achalasia because of the risk of pneumomediastinum and pneumoperitoneum, as well as Z-POEM because of the risk of subcutaneous emphysema and pneumomediastinum. There are, of course, the optical benefits of water that we discuss: magnification, gravity-free, no smoke, no glare, an enhanced precision of dissection and hemostasis. And I think this is proving to be a significant advantage in my practice. The tissue floats, the layers float. So we can differentiate circular from longitudinal muscle layer. We can differentiate vessels because they are suspended in the water environment. And then we can target these vessels more precisely with cautery. And we have reduced collateral injury, the so-called heat sink effect. I use a hybrid knife for my U dissections because it's an all-in-one device. We can use this for our markings around the perimeter. We can use this to inject to lift the submucosa. That's when we make our initial incision around the lesion, and when we perform our dissection, which is underwater. And if we have bleeding, we can perform hemostasis, all with one knife. So we never have to switch out our tools. We can stick with one instrument. The dissection is in fact a hydrodissection. So this is not just a knife that sprays out some water. This is hydrodissection, and that water is coming out at a 120 micron stream that's extremely narrow and therefore very forceful, with a high pressure up to 1,160 psi or 80 bar. This is what enables hydrodissection to leave vessels uninjured so that we dissect out the vessel from the surrounding submucosal tissue. So I'm going to end with a few video examples. Here, first, UPOM. This is how I started underwater dissection. First, the lifting. This is, of course, done with the gas view. We make our 2-centimeter vertical incision. But now we switch to underwater. So we switch the gas off and we enter into the tunnel and we start our dissection with the muscularis propria to the right and the mucosa to the left by sweeping up and down with our knife. This is the T-type hybrid knife. So the disc is very helpful here, especially when we perform the myotomy later. The tip of the hybrid knife can be used to coagulate vessels after they've been isolated with the underwater dissection. So this goes very quickly, and what actually saves time is that we don't have bleeding. We can prophylactically coagulate these vessels before they bleed. What has frustrated me about ESD, about all the third space endoscopy, is the time we lose with hemostasis. And so this is why, for me, it's very appealing to perform this underwater. There you just saw the myotomy. I have another video clip coming up that illustrates this even better. And then, of course, the clip closure today is so elegant and rapid. So this video shows selective circular myotomy. I try to preserve the longitudinal muscle layer. I believe that this reduces the risk of gastroesophageal reflux. The only diseased layer is the circular muscle layer. The longitudinal layer, the outer layer, is not diseased. So here in this video, you can see how the water submersion allows us to differentiate the circular from the longitudinal more precisely because of that buoyancy effect, that lifting effect of the circular muscle layer relative to the longitudinal layer. And we can very rapidly incise the circular muscle layer. In addition, we have the heat sink effect. We have the cautery effect that is limited to those muscle fibers, so we have less bleeding. So just as with UEMR, bleeding is much less frequent compared to conventional UEMR, and here too, underwater myotomy bleeding is much less frequent than conventional gas-guided myotomy. Here's an example of pyloromyotomy. So now the tip of the T-knife is positioned just beyond the pyloric ring here, and we then dissect the pylorus layer by layer, and it is once again that buoyancy effect of water that allows us to peel this like an onion layer by layer. Our objective is to preserve the serosa. So if possible, we do not want to perforate through the serosa. Here you can see how we can visualize in a pinpoint way where the bleeding is coming from, because underwater we can see the precise origin. Now, of course, if the bleeding is too vigorous, then it gets cloudy. But when it's not too vigorous, just as you saw, we can see the bleeding source and target it very precisely. Again, here we can remove these muscle fibers layer by layer, preserving the serosa. And finally, Z-poem, the septomyotomy, the cricopharyngeal, same principle. We start with our incision. This too is a tunnel. The tunnel is just very close to the cricopharyngeal muscle. And then we dissect into the submucosal space on both sides of the septum, on the diverticular side and the esophageal side. So this is the esophageal side now. That's the side you want to be especially careful with, that you don't injure the esophageal mucosa. But once that third space is wide open and all the vessels have been prophylactically coagulated, as you can see here, then we can proceed to perform the myotomy between these two submucosal spaces. So here's the septum, and just as you saw with the G-poem, we are dissecting layer by layer, and we're going to dissect all the way down to the esophageal wall. So the septum starts to thin out, and when it has barely no thickness, that's where we stop, because that's the esophageal wall now. And once again, almost no bleeding. So I find that always so remarkable that we can not only visualize the vessels and target them prophylactically, but also that bleeding is relatively rare. So here are the clips closing the tunnel opening, no different than with a E-poem procedure. Now just finish this real quickly and review a couple of papers. This is our paper from last year, 26 patients, an abstract, 18% with prior Heller myotomy with fundal plication. Technical success, 100%. Clinical success, 92%. Eckhart score dropped from 7.6 to 1.2. 8% with self-limited chest pain. No leaks. No pneumomediastinum. No pneumoperitoneum. And my impression is that these patients recover much faster after underwater. I haven't done a randomized controlled trial, but I think it's the gas that causes a lot of the discomfort, the gas that escapes into the mediastinum that causes the discomfort. My patients are discharged the same day after the procedure. UESD is the new kid on the block, first described in 2018 in a case series in 26 patients. Median procedure time, 60 minutes, no perforation. But again, the buoyancy is the critical factor here that facilitates the tunneling or the dissection in the submucosa. And gastric UESD was reported by Harada in 2018 as well. You'll note that the median procedure time and the median dissection speed, the time was significantly less with underwater ESD compared to conventional. And the dissection speed significantly faster with underwater ESD. So I hope that this presentation at least inspires you to take that plunge into this new frontier of underwater endoscopy. Thank you.